Good afternoon, everybody. I've been given a rather difficult talk with not much literature to support most of the recommendations. So, I'll be talking about the pharmacological therapy in lean MASLD. So we know that lean MASLD has been defined in Western population as a BMI less than 25 kg per meter square and less than 23 in Asians. So it was initially thought that this is a unique Asian phenomenon. But then later studies have shown that except the African continent, most of the population have lean MASLD, accounting to up to 15% of the total prevalence. So in India, if you can see here, there are studies, there are wide varying prevalences, but it has been seen around up to 47% in different studies. So what are the causes of lean MASLD? So it can be both epigenetic, environmental, and also the individual specific risk factors. So environmental causes like a high fructose and a high fat diet, then dual etiologies of alcohol and obesity, then it can be drug related, there can be some endocrine disorders like PCOS, hypothyroidism, GH deficiency, specific genetic causes like the PNPLA3, polymorphisms, then there can be monogenic disorders, etc. Then acquired or congenital lipodystrophies as well. So there are multiple postulated mechanisms. The thrifty gene hypothesis, then there are evidences of maternal malnutrition and IUGR, which leads to lean MASLD. It is found that children born as IUGR to malnourished in maternal deliveries, you see that by the age of 11, they have got significant insulin resistance. And then following that, they have something known as a catch-up growth. During that time, they're prone to increased adiposity in the liver. So this is the famous YY paradox. This was published in the Lancet in 2003. So here you can see both the authors of the paper, Yajnik and Yudnik, who have apparently the same BMI of 22.3 kg per meter square, and when their body DEXA was done, you can see the startling difference between the body fat percentage, with one having less than 10, with the same body weight, of course, they've got very widely differing, body fat percentages. Now, what is the pathophysiology? So like I said, there is insulin resistance, there is something known as a mitochondrial dysfunction, and there is increased de novo lipogenesis, there is decreased subcutaneous fat, there is lipodystrophy phenotype and low muscle mass, and they have higher circulating free fatty acids and decreased adiponectin levels. So there is gut dysbiosis as well, I'll come to it later, and there are specific gene polymorphisms involving multiple genes as well. So this is gut dysbiosis. So it's seen that people who take excess high fat or a sugar component, they have gut dysbiosis, and we can find that between non-lean and lean MASLD, the gut composition, biota composition were quite distinct. And this was a study done in a small sample size. Within, they found in lean NASH that there was threefold lower abundance of Faecalibacterium and Ruminococcus and decreased lactobacillus compared to overweight and obese NASH. And this offers an opportunity to manipulate the symbiotic microbiota for future research. So what is the natural history of lean MASLD? So we can see here from this graph that the lean people or the normal MASLD initially start off with much greater degree of metabolic flexibility apparently, and by the course of time, most of them meet the same clinical phenotype. So initially we find that their metabolic risk factors, their liver enzymes, their hepatic steatosis, and even the biopsy are compared to obesity is much less, but then they catch up, and when they progress further, we find that their liver related outcomes are poorer than people with obese or overweight NAFLD, and the cardiovascular outcomes are almost the same. So this is called as the paradoxical outcome of metabolic maladaptation where, which affects multiple systems like the weight control, the adipose distribution, the energy metabolism, etc. Here we can see two lean NAFLD patients below 60 and above 60, and we find that these people have more advanced fibrosis, lobular inflammation, and they have severe sarcopenia as their age progresses. So all complications of obese and overweight MASLD occurs in lean MASLD as well, and lean MASLD people tend to exercise less compared to the obese, and they have increased risk of colorectal carcinoma, esophageal squamous cell carcinoma, and GERD. And like I said, the liver-related events which you can see in the red are more common in the lean BMI. So the advanced fibrosis, the HCC, all these happens more frequently in lean NAFLD. So there are two phenotypes to it. The type 1 wherein there is with significant visceral adiposity and insulin resistance, and type 2 which is not much of visceral adiposity and is usually associated with monogenic disease. So we can see here that when you compare the healthy lean individual to a lean MASLD, they have significantly increased unhealthy diets and lower physical activities and gut dysbiosis, and they have what is known as metabolic dysfunction, insulin resistance, low subcutaneous adiposity, high visceral adiposity, and sarcopenia leading to steatotic liver. So this is the AGA guidance when you get a patient with lean NAFLD. So if you have an ALT and AST is abnormal, you rule out other confounding factors. If the AST-ALT is normal, you should consider other diagnosis, and the diagnosis of exclusion. You risk stratify the patients for cardiometabolic risk factors, and if you have risk factor, aggressively modify them. Based on your non-invasive markers, patients with a higher FIB4 need to have a hepatology referral pathway, and they should be even considered for biopsy. And if you are considered high risk, or people who are continuing to increase their metabolic risk, even in lean MASLD, there is increasing role in fact for weight loss of 3 to 5%, which improves with exercise their muscle mass, decrease their fat content, and these patients should be advised to avoid fructose and high carb diet. And the only trials which had some degree of NAFLD, so that is the only lean NAFLD, the only things we can recommend are vitamin E, pioglitazone, and also enroll them prospectively in clinical trials. And these people should be aggressively screened for liver related events. So here, whenever you have a suspected lean MASLD, like I said, if it's a type 1 lean MASLD, again you risk stratify them based on non-invasive scores and a fibroscan, and you type them and look out for, these are specific patient-centric approaches where you have a low triglyceride, ApoB and LDL levels. These people could have hypobeta-lipoproteinemia. These people tend to improve with vitamin E. If you have a baseline elevated triglyceride and LDL, these people may have underlying monogenic disorders. And when you have low HDL, you are significantly prone to cardiovascular events. Again, you have to rule for LAL deficiency. So these are in a nutshell how you manage a lean MASLD. So again, all these people consider, this is the recent AGA expert review. This is a consensus statement where they have given around 12 statements, in fact 15 statements. 2 of them are on screening for HCC and advanced fibrosis. So the only drugs that are currently available are vitamin E and pioglitazone. There are few uncontrolled studies on lean MASLD using saroglitazar, but we need more data. So the problem really here is that we really don't know if lean MASLD and obese overweight MASLD are continuum spectrum of clinical spectrum continuum, or are they distinct diseases that require a distinct treatment. And secondly, the trials have largely excluded people with, because the entry criteria they had taken either obesity and diabetes. These tend to be more common in lean or normal weight, less common in lean or normal weight patients, and these people have not been included in trials. So future trials would have to include specifically lean and healthy weight people with NAFLD so that only we can make recommendation. For now, the only thing we can really tell them that are because lean NAFLD patients compared to overweight or obese NAFLD do very lesser exercise and have more sedentary lifestyle, have more alcoholism, so traits. So these people, these aggressive risk factors have to be treated. The patients, even if they do not lose weight, the importance of exercise has to be, kind of emphasized. And these are the recommendation as on date. I finish here. I think I finished well in time. So the 2 minutes of delay, I think, have accounted for. Thank you, sir.